Okay, Assalamualaikum and good afternoon. Today we are very grateful for Dr. Wenzin, who will be teaching us on blocks of the lumbar plexus. So without further ado, Wenzin.
Hey, good afternoon, everyone. It's not teaching; it's a revision. Actually, my aim is aim for a quick revision, mainly targeting us at the bedside to do block easily and safely. So today we'll be talking about blocks of the lumbar plexus. Part 1 is about femoral, LFCN, and obturator nerve block. So we'll be focusing on these 3 nerve block for today. So this is the lumbar plexus. So we have contributions from T12 to L5, and we'll be focusing on LFCN, as you can see in the red box. Bawah got femoral nerve and obturator nerve and obturator accessory nerve. So this is just a table, more of a theory aspect lah. Femoral nerve is contributed by L2, L4. Distribution, it's a mixed nerve. It has got a motor innervation and a sensory innervation. So motor supplying the anterior muscles of the thigh, which include the sartorius muscle and the quadriceps, and adductor of the thigh, including the pectineus and the iliopsoas muscle. And sensory is to the skin over the anterior medial surface of the thigh, medial surface of the leg and foot. For our LFCN, lateral femoris cutaneous nerve, is contributed by spinal segment L2, L3. It mainly is a sensory nerve, so it covers skin over the anterior, lateral, and posterior surfaces of the thigh. And lastly is the obturator nerve, is contributed by spinal segment L2 to L4, and it's a compound nerve. It's a motor and sensory nerve, motor to adductors of the thigh, meaning adductor magnus, brevis and longus, and gracilis muscle, and sensory to the skin over the medial surface of the thigh. So going into femoral nerve block. So it's one of the very common and useful nerve block in our regional anesthetic block. Quite simple and superficial, quite easy to do. So usually it's indicated for surgery procedure involving the anterior thigh and the knee to a variable area of the medial aspect of the leg. So this is the anatomy where the femoral lies in our anterior thigh. So as we know, from medial to lateral is VAN, vein, artery, and nerve. So the next slide I'm showing is more of this is a osteotome distribution. We have a myotome distribution, and lastly is the cutaneous distribution of the femoral nerve. This is just a repetition. So this slide is just to show it's a compound nerve. It has a motor and sensory nerve, and there is particularly is articular branches to the hip and knee. So how do we do it? For all the nerve block, all the peripheral nerve block, these are the basic and essential things that we must do. Consent is a must. Correct site, sebelah mana, right indication. Make sure the IV access is available, and we have to monitor the patient just like how we monitor the patient when we are giving a basic anesthesia, blood pressure monitoring, SpO2, ECG. It must be done under aseptic technique with a trained assistant in an awake patient. So this is the position of the patient. As you can see in the picture, this is actually blocking the left lower limb of the patient, left femoral nerve block. So ultrasound will be in front of you, opposite to the performer, and then this is an in-plane technique. So this is how it will appear comparing an ultrasound image and a cadaveric dissection. So as you can see, you put the probe over the femoral nerve. From most superficial downwards, you have the cutaneous, you have the skin, subcut fatty tissue, and the most important thing is actually you have to know how to identify fascia iliaca. because your femoral nerve lies below this fascia. It's not above. If you deposit LA above this fascia iliaca, it will never work because the nerve is below. So this is another image showing how it's supposed to look like. So when your LA successfully surround the femoral nerve, this is a sign, it's called a donut sign. So I'm showing a lot of pictures to help us to identify and familiar ourselves with the ultrasound images. So as we can see, from the right side onwards, the right side is the medial. So VAN. So as you can see, vein, artery, and nerve. So remind yourself, you must be below fascia iliaca. Then only you can correctly identify the nerve. That side, I realize, if let's say sometimes we struggle and we can't identify the femoral nerve, we tilt called cephalic. Your probe, you fan, you tilt cephalic, slightly point towards, and you can get an enhancement of the femoral nerve and a better visualization. So this is just another ultrasound image to show, because everyone, the anatomy is different, but the most important thing is you must be able to identify the fascia iliaca, and you just scan upwards and downwards, and you track, make sure it's the correct nerve. This one I'm showing because this performer is actually putting the probe slightly distal to the inguinal crease. That's why you can see your femoral artery start to have branches, which you have your lateral femoral circumflex artery and your profunda femoral artery. This one meaning actually you're a bit distal. So means you actually have to slide your probe upwards a bit, more cephalic. So femoral, how much to give? Usually it's about 10 to 30 ml of LA. So same to all the peripheral nerve, you give in small aliquots. So it means you give like aspirate after confirming it's a negative aspiration. You give in probably 2-3 ml. Then after that you aspirate again, and then you give some more. Yeah, you must always check back whether are you at the right position, place. At the same time, your eyes fixed to the ultrasound screen. Make sure your LA is depositing at the right place. Okay, this is the ultrasound image trying to show the donut sign. As you can see, can you see the nerve floating around the LA? That's the donut sign. So that's about femoral nerve. So LFCN, we are going to LFCN nerve block. To me personally, this is one of the very difficult nerve that to identify, because sometimes I can see, sometimes I don't. So after I read a bit for the presentation, then only I know there's a trick to it. So later I'll show you guys how to what's the trick about it. So the indications for the LFCN nerve block usually is for post-op analgesia, mainly targeting for hip surgery, neuralgia parastica, muscle biopsy of the proximal lateral thigh, because it provides the sensory to the lateral aspect of the thigh. So the LA actually not much, it's only 5 ml in adult. This is how we put the transducer position. Usually after the femoral nerve block, you just slide towards lateral, and this is roughly the position. So what happened when you put the probe on top of the skin? So on the probe, superficial downward, as you can see, the main landmark is you need to see the sartorius muscle. So as you see the sartorius muscle, you try to identify the lateral muscle, the muscle lateral to it, which is the tensor fascia lata, and you try to aim the area in between the sartorius and the tensor fascia lata. As you can see, the LFCN is actually quite near to sartorius. So the the trick is your LA is go to this fat filled flat tunnel. It's triple FT. So articles say that sometimes when you can't see, it's okay. You just deposit in that triangular area. I'm going to show you the next diagram. As you can see, there's a triangular fat filled area, like a tunnel, in between the sartorius and the tensor fascia lata. So that is the rough area for it. Again, the same ultrasound images. That's trying to show, as you can see on the left side of the screen is the sartorius muscle, which is your medial side. Lateral to it is the fat filled flat tunnel, and lateral to it is the tensor fascia lata. This is the area that you can block your LFCN. So that's about LFCN. So going into obturator nerve block is relatively rarer to perform in a day-to-day basis nerve block, but sometimes it can be very helpful, especially when you have a patient going into TURBT for a lateral wall tumor, lateral and posterior wall tumor, because you won't want the patient to have the obturator kick and causing the bladder perforation. So just a recap, obturator nerve is from the lumbar plexus. It's a compound nerve, sensory and motor innervation to the medial compartment of the thigh. So as you can see in the diagram, we have contribution from L2 to L4, and as the nerve travel, it divide into anterior and posterior branch. This is just a recap for muscular branches, articular branches, and cutaneous branches for the obturator nerve. This is a pictorial demonstration of the osteotome, myotome, and the skin sensory of the obturator nerve. So the indication for the obturator nerve block, mainly it's used for TURBT. Like what we mentioned just now, actually is more of a prevention of the obturator jerk, especially during the TURBT. This is to reduce the risk of bladder perforation as a result of the obturator jerk. So some they will do it for the hip surgery, rarely do for knee. Sometimes in the chronic pain, they'll do for the hip adductor spasticity or a certain pain therapy. So I only know about the distal approach for the obturator nerve, but according to WFSA, we have two approach. One is distal, one is proximal. So for obturator nerve, actually it's not that easy. It's not a straightforward nerve block like a femoral nerve block, or you put the prop there, then you can see, oh, this is femoral nerve. No, this is actually quite difficult. And sometimes it can be operator dependent. So this slide is trying to show the prop position for a proximal approach. So as you can see, the prop position, the blue color there, is almost near to the inguinal crease, and is very near to your pubic rami. So we go into distal approach first. So as the distal approach, we expose the medial part of the thigh, and our ultrasound probe actually have to go quite medial to the thigh, and the needle will come in from lateral to medial. Usually it's an in-plane approach. So the common length of needle we use, usually you use longer, maybe 100 mm. This one, WFSA, they just put 8 cm long, at least minimum. So this is how it looks like. On the left side of the screen is the lateral. This is medial. So when you put the prop there, then you can see all the adductors, Alabama. So it's adductor longus, adductor brevis, and adductor magnus. So the usual anatomy is the anterior branch will run between the adductor longus and adductor brevis around the fascia plane. If you can identify the nerve, that's the best. But if you cannot, usually we aim to deposit the LA around the fascia plane. Then the posterior branch will be somewhere in between the fascia plane of the adductor brevis and adductor magnus. So same thing, we aim for the fascia plane block. So this ultrasound image, actually this performer able to identify the nerve, that particular nerve. So you can see the obturator anterior branch is between the longus and brevis, and at the posterior branch is in between the brevis and magnus, as it's pointed out. So this is to me, this is quite easy lah. Just deposit at the fascia plane, it is quite safe. You won't injure the nerve. So how much to give? It's about 10 mil. If you choose bupivacaine, you can aim for 0.5%. If you choose ROPI, you can aim for 0.5% as well. So we already know the anatomy, so you deposit 10 mil each of the LA near to the nerve or at the fascia plane. This is another ultrasound images trying to show. Oh, this is a proximal approach. Sorry, my slide a bit blurry. I show the proximal approach first. Okay, this is where you block for proximal approach. So just now the distal was a bit lower. Then you can view the three adductor muscles, Alabama. This is higher up. This one, you need to visualize the cutaneous and the obturator externus. This one I'm not too sure. If I'm wrong, then you just correct me. Yeah. So how we do it, you can put the probe in line to the inguinal crease, and then you try to identify the superior pubic rami. You have to tilt a bit up lah. As you tilt up, then you can see the pubic rami, and this is how it appears like. So on the right side of the screen is medial side. Whenever there is bone, that's your medial side. Yeah. So superior pubic rami. Then you can identify where is your cutaneous and where is your obturator externus, and it's in between. This one, you don't have to deposit LA at two places. This one is only one place. One, and that's it. This is again the same ultrasound image demonstrating the proximal approach of the obturator nerve block. Same thing. So at the right side of the screen is the medial of the patient. So superior pubic rami, and then you identify the obturator externus and the cutaneous. In between is your obturator nerve. This one is quite clear. So when I was preparing this slide, then it struck my mind. So which is better? Should we paralyze or should we block? So I tried to find some information, and there's a good literature that I'm going to share later. So which one is better? Obturator nerve block? Should we block? Should we paralyze? So clinically, actually, to us, not much of difference. So we go through it lah. So obturator nerve block is more specific rather than your neuromuscular blockade is general. You have to paralyze, means you have the secure airway already. And then scope, for the obturator nerve block, usually it's mainly used for the patient under spinal for TURBT lah. Your paralysis, you can use for laparoscopy, you can use for robotic surgery. This one is quite general. And the technical level, obturator nerve block is not performed regularly and on day-to-day basis. So actually you need to be trained for it lah. Paralysis, bagi je. Yeah. So this is an article from Pain Medicine BJA. This is 2021 article. So it actually compare between obturator nerve block versus neuromuscular blockade for prevention of adductor spasm, which is our obturator nerve jerk, in patient undergoing TURBT. This is a RCT. So all the patients is under GA. They just compare only whether is it paralyzed or is it under nerve block. So actually nerve block, the incidence of the obturator nerve jerk is lesser. But unfortunately, the study is quite small. So in the end, it's not significant. That's the primary outcome. The secondary outcome, actually, they got see, okay, you block the nerve. Sometimes we worry we block the nerve, patient weak, and then in the ward jatuh. So this is the secondary outcome. Post-op assessment of fall risk. Actually, there is no difference. Means the nerve is as good as your paralysis because you reverse. Usually adequately reverse, patient no weakness. So obturator nerve block actually doesn't really cause weakness and causing fall subsequently. So they recommend both techniques are actually quite safe and efficacious. You can do either one. So this is one of my last slide. This is a general complications to all the peripheral nerve block. So your block can fail. You can aspirate intravascularly. You can have LAS. You can have nerve damage. It can be temporary. It can be permanent. And you can have injury secondary to numbness or weakness or infection. This is just a general complications. And I think that's about it. That's all. Any question you guys want to ask?
Okay, I just want to highlight personally, I've never even considered the proximal approach to the obturator nerve, but when doing the distal approach, you can see in the diagram, your approach is from anterolateral to posteromedial, and you are trying to get your needle in between the adductor longus and brevis, and then followed by getting the needle in between the adductor brevis and adductor magnus. The problem is that you must make sure that you plan your needle path correctly, because in your path will be the important structures of the FAFE as well as the femoral nerve lah. So you have to be mindful of that. Okay. The most When it comes to doing an obturator nerve block for TURBT, I know that we don't do TURBTs here in Melaka, but in other urological centers. So that's why most of the time, if we have a TURBT, we will just give the patients GA lah, rather than a spinal, because then you don't need to think about whether to do an obturator nerve block. However, in patients where it's not where doing a GA is risky, for example, in patients with potential difficult airway, and so I personally have done last time in HKL give a spinal and then followed by obturator nerve block, because that patient had a difficult airway. So it can be done for that kind of indication. So I just want to ask Wenzin, so in university, what is your regime for AKA? Do you do obturator nerve blocks for AKA? You did lah. In the literature, did anybody talk about it or not? Or you didn't see it? So personally, I do obturator nerve blocks for AKA because it will cover the adductor portion lah. So if you do a BKA, there's no need to really consider obturator nerve blocks. But for AKA, I would consider doing it because it is part of the surgical field. Whether it's that significant or not can be up to debate lah. But personally, I do. But the problem is, if let's say, can you just go back to the slide on the dose? Because the problem is that if you want to do an obturator nerve block, at the end of the day, the obturator nerve block is not as important as your femoral and sciatic. So the majority of your allowed dose will all go to your sciatic and then followed by the femoral, and then the rest of it can go to your LFCN and obturator nerves. So these are all things you have to take into account. Personally, I don't usually with my calculation, usually I will just give 0.25% of ROPI lah for the LFCN as well as the obturator nerve. I don't really give 0.5%. And then so usually I will give 5%, 5 mil of 0.25% for the LFCN, and then 5 plus 5 for AON as well as PON of 0.25%. This is because taking into account that you're already gonna give a relatively much higher dose for the more important nerves, which are the sciatic and the femoral. Okay, any questions?
Actually, last time when I when I was doing my regional posting, unfortunately there wasn't pain specialist. There was this one time, I'm talking about peripheral nerve block per se. Then I was thinking, I was so scared that time. I will use dual method, nerve stimulator plus ultrasound. So I think femoral quite easy to see. I don't think it's a necessity to use nerve stimulator per se kan, as long as you get under the facial plane.
I mean, I've had many cases where I couldn't identify the femoral nerve. It's not as straightforward. I think can you just go back to your slide on the image contoh, the example images of the femoral nerve block. Okay. I think the first thing that you need to take away from the diagram is that you need to go as proximal as possible for the femoral nerve block, because as you go more distal, the femoral nerve block has already started to branch out. So one way to know that is that once you see the common femoral as well as the artery as well as the common femoral vein, then you know you are in a good place. Okay, so even from this diagram, you know that as you go more distal, the femoral nerve has already started branching out. Okay, can you just go to the next picture? Okay, so if you look at this particular picture, the femoral nerve is not exactly adjacent to the femoral artery. It is below the fascia iliaca, above the iliacus, and in this picture, the nerve appears circular. Okay, can you just go to the next slide? And then suddenly you have a femoral nerve that now appears elliptical. So one thing to highlight from this Naisora illustration is the fact that even though they travel together, the femoral nerve as well as the femoral vessels are not in the same fascial compartment. Okay, so the femoral nerve, even though it is adjacent to the femoral artery, it is actually part of the fascia iliaca compartment. And in this particular picture, you see that the FN is elliptical. Okay, next. And then suddenly you see a femoral nerve here, which is a bit more triangular in shape. What I'm trying to highlight is that the femoral nerve is highly variable in the appearance. So the most important thing to do is actually to make sure that you identify the iliacus and the fascia iliaca correctly, and then you track the structure cranial caudally lah, so that you can get consistency and you can properly identify the structure. There have been times whenever I could not identify the femoral nerve readily, I will just put a needle below the fascia iliaca and then head towards the femoral artery and then hydrodissect and then see what are the structures that I'm able to identify. At the very least, if you see cell line that is not in the fascia iliaca compartment, you know you are too superficial. And then and then you just have to go deeper until you are able to identify. Sometimes just by giving cell line, you get contrast and you are able to identify the femoral nerve within the compartment. I think, is there one more picture?
Got.
Yeah. Before that? Yeah. So if every single slide that Wenzin has shown, it has shown a different morphology of the femoral nerve. So that's why it's important to have principles in mind on how you want to identify the femoral nerve, especially in those where ultrasound is not so easy. Okay. So last call for questions. Okay. If there are no further questions, I think we will thank Wenzin in the usual manner. Thank you. Bye bye.